Okay, welcome to another episode of That Naturopathic Podcast. It's Dr. Dave here. And of course, got my sidekick, Dr.
Hello.
Michelle Pobega. What's up?
Hello.
What's going on, Michelle?
Oh, enjoying the week off. It's been lovely.
It is.
So,
It is lovely.
but I'm super excited for our guest.
Yeah, we know this. We know this guy. I thought he was my boy.
No, we go way back.
Yeah, he's your boy, actually.
Justin's a way back playback for me.
Yeah. Well, we could clarify your history with him before people get the wrong idea.
We have mutual
it's just
friends.
a Weezer concert.
It was just yeah. No, we both grew up in Hamilton, and we had we have mutual friends. He was friends with the brother of a friend of mine, and then we all just kind of hung out together. And it's been like at least well over a decade now, so it's kind of fun. Probably like 15, 16 years. We've gone to some concerts.
Yeah, you got me beat. I only known him for a while. So why don't you give a little official intro to our naturopathic brother, Dr. Justin Gallant, who's been on the episode 2, I believe. He was on Iron Man. Yeah. Come on, give a little full. Yeah, Michelle, give him a little full intro.
You always do the intros. You're throwing me for a loop.
I could introduce myself if you want. I don't mind. I'm trying to figure out how to share onto my own professional Facebook page, but I think maybe I'll just share it afterwards. It's not happening.
Okay, I like this. Here's a couple things I like about Justin Gallant. I like this. He's a health detective and a health educator. I like that. It's on his website, so it's very clear. And he's just a damn good clinician, and that's why you're on the show.
Thank you very much. I'm trying to transition myself into a health optimizer because a health detective has proven to be a very complex, complicated career. But I do still appreciate complex cases. And I do pride myself in like getting down to the bottom of what's going on, which I know all of us naturopathic doctors do.
I think that if you're even going to call yourself a health optimizer, you're down for some complex roads, because like nothing about getting people back on track in this world is like linear.
I know these days are tough for everybody. It's been wild.
Yeah. So
okay. So Justin, we had you on, like I said, episode 2. I really
good episode.
It is. It's probably one of I'd say it's got to be one of the most important ones I think we did from a clinician perspective, and also for anyone who's got possible issues with iron. It's a resource that I send people to all the time. But I wanted to reach out to you again. So I guess it was in the last month or so I reached out to you. I said, Justin, I want you back on the show. You're the gangster shit. Come on, drop some wisdom with us. And what did you say? What did you say we should talk about?
I said we should just break down all the different labs. And I am a lab addict. Like I love to look at blood work. My eyes light up when I see it. And I've recently heard that naturopathic doctors these days don't actually get education in labs, which is just
at the school?
Yeah. I don't know if it's true, but I've heard that from quite a few different NDs that they do not have a lab class anymore.
That's absurd. Crazy. I mean, I know when I came out of school though, and this was something that I think I had to get over for a long time, even though we did have that education, because we're not OHIP covered, I always found it an interesting conversation to have with clients to get them on board to pay for that kind of testing when they're like, oh, my doctor can just pay for it. It's nothing unique that you'd provide me. But now I'm getting like, over the last few years, I've realized how much more important that is, because so much is overlooked. And I've become a lot more of a lab. I'm sending requisitions to a lot of people now, doing like comprehensive panels, and people are like, I'm willing to pay because no one's figuring things out. And people are just like throwing the money, being like, I don't care how much it is, just figure things out. And so I'm getting more comfortable with that. And I appreciate having this topic, because I think a lot of people were in the same boat as me, where you felt you have like trepidation about asking people for more money for their health. Right. Yeah. And I feel like when you're willing to pay the money, you can look for whatever you want rather than being limited by what Ministry of Health deems acceptable.
That's right.
So
yeah, we can fish around a lot more without those restrictions, right?
That's all. Yeah, exactly. So I'm excited for this talk.
Okay. So Justin, why do you think it's so important, like to your day-to-day clinical practice? Like obviously you get your rocks off looking at labs. I get it. I do too. It's fun. It's like a whole new world or perspective of looking at things. But why else do you think it's important just like clinically for your patients?
I'd say tracking progress is a big one as well, because, you know, if somebody's feeling lousy and let's say they have an iron deficiency and 2 months later they're still feeling kind of lousy, but we see that their iron's coming up, it's just a matter of time before they're at that point. So it does give you some objectivity towards progress, something to be able to track objectively.
Mm-hmm.
I think that's a big part of it for sure.
And then ruling out things, I find it helpful a little bit for that too. Like I think your episode on iron really, I think ever since learning a little bit more about iron from you, I think I've gone down the lab rabbit hole even more, and I do more and more stuff, and I find the same sort of reasons to go into it, because like things are not often evaluated from a optimal perspective. They're, you know, they just put maybe you could talk about that a little bit, how everyone sort of fit into this bell curve, and that's a major sort of
the line of fine.
Yeah, and it's
fine.
It's a foundational
That's
sort of
right.
pinning that is really important, I think, for the average person to know, and for clinicians to know if they don't already.
Yeah, totally.
Yeah, I guess that's the most common thing we hear is someone will get blood work done through their family doctor, and sometimes not even the family doctor tells them. The receptionist will say everything was fine, right? And you know that they're just looking to see if something was flagged. And there's like, if you think about hormones don't even get flagged, right? Because they have to be interpreted. And so there's all these ranges that have been created that kind of like, let's say free testosterone as an example. When we all first started, the cutoff was less than 28, and now magically it's less than 56. And there's labs like the iron that we talked about, or the ferritin, where the the reference range is 5 to 272.
Oh my God, it drives me nuts.
I know, honestly, I need to like sit down with Life Labs and be like, okay, we need to reassess this reference range, right? Because these ranges are basically just making sure you're within that 95%, and they're kind of making sure that maybe you're not going to die, but they're not like anywhere near optimal, right?
Right. You don't have X disease,
Yeah,
but it doesn't mean you're great either.
That's right. You're struggling for sure.
Yeah.
And I think labs are just something that we are very fortunate to have access to, because they can tell us so much. And like you were saying about the cost, I originally, when I first started, it was the same thing. I was like writing doctors letters asking to get this, and this done. And I haven't done that for years. Like, I just basically say, these are the tests that need to be done according to what's going on with you. If you like want to see if your family doctor, because your doctor's, you know, laid back and is willing to do this stuff, you can always bring this rec and ask them to check these things off and get OHIP to cover them. But otherwise, it'll speed the process up. If you take this requisition directly to the lab, the results come directly to me, and then I can interpret them. Whereas if you do them through the family doc, you have to make an appointment, which is next to impossible these days. Then you have to get into the lab, which I don't know in your areas, but it's next to impossible in Hamilton. Then you have to wait for the results to come back, and then make an appointment with your family doctor to review the results, and then get them to me, which is just like, that's weeks that it's going to take, right?
Yeah.
So in terms of speeding up the process, I usually just recommend, you know, it's going to cost approximately this amount. It'll be done a lot quicker, and most patients are great with that. Yeah,
I mean, there's time, energy, money, resources, right? And so in terms of money, I think we come at the, like Michelle was saying, I think at the beginning, like, you don't want to ask people to spend more money on this sort of stuff, but like, as you get, I think, a little bit more comfortable in the exchange of things economically in practice, patients don't care, man. Like for that pain in the arse that you're talking about, to that like administrative pain in the arse, and dependent on many things, such as, like, I always ask people, what's your relationship with your doctor? If they want to do it, I said, what's your relationship with your doctor? Because if it's really good and cordial, like, I have a guy in town, he'll do whatever I ask. He's actually my doctor. He's a wonderful guy. And I think he has a certain level of understanding or respect for what we do as naturopaths, and maybe just me or you or Michelle or whoever it is, because we're all very different. I don't think any of us are using like a Vega machine. Like maybe if I did that, he maybe wouldn't think that.
Yeah,
But like,
exactly.
but I mean, I think just, I don't know what you get people to invest in labs. I would, or you, Michelle, but I would say rarely is it a lot more than $150 for very thorough lab investigation. Like what's
Usually
it
the
like for you
average.
guys?
I don't know. I'm finding like 200 to 300 because if I'm doing a comprehensive lab analysis plus a thyroid panel, especially for women, then it comes to about $3 bills.
Yeah,
Right.
if you're doing
That'd say
the thyroid
that'd be the
alone.
max, right?
But
Yeah.
that's the most. That's the most when
Mhm.
it comes to just standard comprehensive. But you know, and also I just feel like you were talking about the practical side of going through that. But how many times have people say they have a great relationship with their doctor? He's super cool. He's even open to me seeing a naturopath. That's great. Awesome. And then I send them with the things that I think are the most relevant, and they do half. Right.
Yeah.
Or they cherry pick, or they only run TSH versus a thorough thyroid panel. And then I've run the full thyroid panel. I'm like, and your antibodies are excessively high. So that needs to be understood. Or I'm running liver enzymes and it's crazy. Or I'm running fasting insulin. I don't understand why doctors don't run fasting insulin. It's really
I know.
bonkers.
I say that to myself every day. The fasting insulin is so important.
Yeah. So I also appreciate the fact that we're just more explorative and more investigative, the detective side of us. And we end up uncovering a lot of really valuable information to support our clients' well-being. And I position it that way too to my clients. Just be like, you've gotten the standard lab work before and your doctor keeps saying you're fine. So why don't we be a little bit more comprehensive about this and see if there's anything else that the body's trying to tell us?
Mm-hmm.
That's right. And that $150 to $300 is what, like a pair of shoes or two? You know what I mean? Like
a hair appointment.
Yeah, exactly. I know my wife runs a hair extension business, and I have patients who I see them going to see her and not seeing me. And it's like, and another thing is if you have benefits, a lot of the benefits will actually cover
Yes.
blood work, right? When we do direct billing. So
yeah, it's pretty great. So I feel like everyone should just be a little bit more comfortable with investigating in their health.
I have to say though, like most people are. Like
these days,
I don't run into too many, especially when you talk about like what you were saying there at the beginning, to Justin, like look, like we can do this, but it's a real pain. I mean, $150 to do some stuff that is often going to help figure out what's going on or monitor progress. And maybe it's not even done all the time. Like I would say most of my labs, I'm not doing them all the time. It's not like this is something
exactly
all the time, right? So
yeah, usually you have that more expensive first one that's kind of like exploratory investigating, and then after that, if you're tracking progress, it's going to be like less than half the price of that original test, right?
What are your go-tos, Justin? Like, what do you find if someone, like, are there certain ones that you find that you're often recommending for clients, like as a good, just thorough workup? What do you find?
Yeah, I know. You know what? I have to look into the panels that they have to offer, just because I have heard some NDs are like running the panels that are direct or pre whatever. But I would say my most common would be like CBC, vitamin D this time of year, especially. Like I like to try to test it between October to January to see where it's at. I always test calcium with vitamin D. We'll go into more detail with this stuff. If like I do run the day 21 estrogen, progesterone, testosterone if it's indicated. I do run a lot of iron as well as ferritin at the same time. I believe that they should just be combining them. They shouldn't even allow you to test one or the other. And that's a crazy thing we talked about in the iron podcast is like that when you get your testing done through the family doctor, if they check off the ferritin and the iron panel, they'll automatically delete the iron panel. They can't test both at the same time, right?
It must be an OHIP.
It is. Yeah, that's right.
Yeah, crazy.
Yeah. Dave, I think your microphone is a little staticky.
I was just going to write him that.
Okay. I would say, and there's lots. I run so much blood work. I think a good structure for this would just be like, we'll kind of go through, we'll talk about the things that we just don't test, because there are quite a few on here that we don't really do. So yeah, do you want me to start?
Yeah.
Dave, are you still there? And good.
Yeah. Can you hear me all right?
Yeah,
Much better.
you're good now.
Okay.
Yeah, so like I said, the first two that are on there, the healthy living assessment and enhanced living a healthy living assessment. I haven't really acknowledged those yet. I probably should, but just haven't had time.
I'm going to say something I recently did, because when I was picking and choosing things, I found that sometimes the labs would miss all the little various check marks. If I just check off the panel, it's more encompassing, and it includes a lot of the things like the liver, the cholesterol, everything is all in there, and the vitamin D. So the enhanced living panel is kind of like my go-to now.
Okay,
For a first one-off, but just FYI.
Well, guys, let's make sure we talk about what's on the panel, because people may not know exactly what's behind the scenes with what's in the panel.
So that includes, do you have that list in front of you? Is anyone? I could too, but I know it includes the CBC, ferritin, B12. It includes the iron panel. It includes cholesterol, it includes your electrolytes and your calcium. It includes your ESR, your inflammatory markers, ESR and HSCRP. It includes vitamin D, fasting insulin, fasting glucose, but you have to tell them obviously to go fasting, and your HbA1c and kidney markers. Did I say liver enzymes? Because that's in there too. It's actually pretty comprehensive, and I like that.
Your brain is a lot better than my searching skills, so that was great.
Thanks. Sometimes she works.
One thing that's super important that I feel like I'll forget to talk about too is making sure that you do go fasted, because what I've been seeing a lot of lately is patients going to get their cholesterol tested and their family doctor saying that they don't have to fast for it anymore. And then all of a sudden their cholesterol looks high. And then if I send them back fasted, their cholesterol is completely fine. And they were prescribed a statin in between. And I just read a stat not too long ago that what you eat can affect your cholesterol levels for up to 7 hours.
Oh, really?
Those ranges, yeah. And those ranges are based on a fasted population. So we don't want to be like, snacking down on a bunch of foods that are going to elevate our cholesterol and then tests.
And we don't want to abnormally skew our results into a place that makes us anxious and worried. And frankly, I'm also just not worried about cholesterol for the most part. I think it's honestly
pretty trigger happy with cholesterol.
Yeah. And I was just like, I was reading in my recent book that I'm reading, and he was like, it is just nonsense. It's actually, certain countries have shown that higher levels of cholesterol as we age is actually protective for us. So our levels should kind of increase as we get older. And I was like, well, that's new. Nobody talks about that.
Well, it makes sense, right? Cholesterol is the building block of all of our hormones. So if our hormones are starting to drop, we're going to produce more of the building block to try to make up for that, right?
Cholesterol is pretty badass, and we need to start giving it the credit it deserves.
I know.
And vitamin D precursor, right? In every single cell
hormones, membrane. Neurotransmitters, brain health, like cell membranes.
It's just getting, what do they call that? Thrown under the bus.
Yeah, it's basically getting the blame for other problems in the body, because it acts as the body's band-aid for all the problems, where it's really, and I think that's a big part of the education that we do with people coming in with cholesterol and their doctor saying, oh, it's excessively high, and they're freaked out. And I'm like, okay, let's take a look at some of these other parameters, like your blood sugar, like your stress, like your, right? So.
Yeah. And running the Reynolds risk score is always good too, right? So they can actually see, how relevant their cholesterol is, because
what's a Reynolds risk score?
Reynolds risk score is a more advanced version of the, oh my goodness, what's the other one called? Where it's just a couple.
Framingham?
Framingham. That's right. Reynolds risk score takes into account, like, if you're a smoker, what your systolic blood pressure is, your age, if one of your parents had a cardiac event before 60, like there's a bunch of other parameters.
HSCRP, that's cool.
Yeah,
HSCRP, HDL. So it's just a little bit more comprehensive. And I kind of look at the cholesterol as like, because there is a lot of debate, and there are a lot of factors. Like if somebody has high blood pressure and kind of all the other factors, I like to try to, like, if let's say their triglycerides are through the roof, I'm going to want to bring those triglycerides down, right? So, and you have to think from the patient's perspective too. It's not really fair for them to have to go from somebody who's scaring them against cholesterol and then somebody who's saying cholesterol is completely fine. It just leads to that confusion. So you kind of have to meet them in the middle and like go through all of the factors that you were mentioning, like their blood sugar and insulin and inflammation and all that stuff, right?
And liver health.
Liver health.
Getting into that one in a big way.
Yeah.
Yeah.
So speaking of that, we have cholesterol next.
Yeah.
The lipid assessment panel. I do like to run that just as kind of a general, like if we're running the insulin and the blood sugar, the cholesterol is kind of like, especially if somebody's younger. Is my mic muting at all? Like,
you're good.
Okay. I put it on do not disturb and I'm having like a million messages come through for some reason.
No, you're clear.
Okay, perfect. So yeah, I do like to run the cholesterol panel, and sometimes I'll use that as a frame of reference as well, because if, like I said, with triglycerides, they're supposed to be less than 1.79. And if somebody comes in with a triglyceride level of a 3, and we do some dietary changes, and then 6 months later, we see that go down to like less than a 1, and we know that we've made huge progress, even if they haven't seen it, visually, like in terms of weight loss or anything, right?
Yeah.
Mm-hmm. It can be motivating in a way too, right? Like somebody like you're talking about this lipid panel, like we were talking about, maybe a bit of dubious or sometimes really helpful and sometimes maybe not the most worrying thing. But if that's going to motivate someone too, right? If someone's very motivated by it, hey, let's help, get them towards their goal and give them what they want and how they need, and what they need exactly.
Yeah.
Right.
Yeah.
And I do have patients who are on the keto diet who just want to check on their cholesterol to make sure that it's not like up at an 8 or a 9 or something. And
right.
So it is kind of cool to see the variation with that too, because the majority of my keto patients, their cholesterol is like squeaky clean, optimal. And then there are some where it just all of a sudden goes like through the roof.
Mm-hmm.
So it's kind of cool to like be able to see how different people react to different styles of eating, right?
What? You're saying not everybody's the same?
I know. Can you imagine that?
Some people don't react the same way to the same diet.
I know.
Wild.
It is wild.
Individuality. Who knew?
But it's maddening too, right? Like, I mean,
Yeah,
I almost wish it was easier. Like,
yeah, it's true.
I don't love that it's a pain in the ass to individualize things, but you got to do it.
Yeah, you got to do it.
It's the cornerstone of good health.
We also have the thyroid panel, which you brought up, which is very, very important. And I run that quite often as well, especially because mostly we're just seeing TSH being tested and everybody told that their thyroid is completely fine.
Mm-hmm.
But then, and sometimes a more progressive doc will do T4 and they'll say everything's fine. T4 is within the range. But then you have to think T3 is the active thyroid hormone. So we want to see what T3 is actually doing and make sure it's on the higher end, if anything, to be stimulating the rest of the tissue. And then if that's low, the thyroid panel gives you reverse T3 so you can see if they're channeling it into reverse T3 instead. And then one really important thing with the thyroid panel is the thyroid antibodies, which is that anti-TPO they brought up. I can't remember what we talked about before we went on air and what we talked about when we started, but the TPO is huge. Hashimoto's is so common and it is just completely disregarded in the conventional side. And it just blows my mind. Like the cutoff is you have to be less than 35. I'll have a patient who's a 500. I'll send the blood work to their family doctor saying, can you do a thyroid ultrasound? And the patient is told this test doesn't matter at all. Mm-hmm. It's like, how can you say such a thing?
It's heartbreaking. It is
heartbreaking. I know. And then we finally convince them to do a thyroid ultrasound and it's like, oh, they have nodules and their thyroid's enlarged and they do have a thyroid issue and it explains all of their issues.
Mm-hmm.
And one thing that I've seen with Hashimoto's is that usually the rest of the thyroid markers don't matter. They'll have a normal TSH, normal T4, normal T3, but as long as their anti-TPO is elevated, their symptoms will correlate with that more than the actual rest of the thyroid panel.
Well, isn't it that your antibodies can be elevated for years before it actually affects the TSH and hormone levels? That's what
it seems like, yeah. Because I like the ones who have had elevated anti-TPO for years and nothing was done, usually that's when their TSH starts to come up for sure.
But you just mentioned something in passing there, though, Justin, which I think is really important principle, is that we're looking at labs in the context of signs and symptoms in history.
Mm-hmm.
Right. And I think some of that stuff that's really basic, I think we should still say, because you're probably going to have a lot of these things that you're looking at in most people or in a lot of people, but in other people, you're going to pick according to signs, symptoms, history. And I'd say doing that, I rarely get a lab, like a bunch of results without something found. I always find something.
I know. Yeah. I always highlight it in yellow too. And it's just like, I feel like that allows but the patient, once they see all the yellow, they're like, okay, we have to do something about this.
Yeah.
Whereas if it's like, yeah, this one's a little bit too high, this one's a little bit too low, then they don't care as much.
Right.
So I do find that that's helpful for sure.
And then we're also like working in optimal ranges rather than just reference ranges. So even then, it's not just what's flagged by the lab, it's also what's going to actually get you to where how you want to feel and make your body work at its best. So I'm already highlighting stuff that hasn't been flagged.
Yeah.
And I imagine you guys are doing the same things. Then you're going through it and like the client comes in being like, oh, it's only like 2 things are flagged. And I'm like, well, and then I'm circling a bunch of stuff and they're like, oh my God. Right.
I know.
Yeah.
But there's a trend, right? Like that's another thing I find generally conventional. I think Justin sort of breezed over it, but you know, in the conventional view of labs, I think unless something's off, there's nothing's really said about it. And each thing is looked at sort of independently as just that's just that there.
Yeah.
As opposed to like, okay, maybe sometimes maybe you guys get this too, but I'll find like one thing that's like off from a conventional sort of like perspective. And then I look at the other, I use the right side of my brain and sort of look at this trends in other things that might be clinically related, anatomically related, or somehow related to that result. And you go, you know what? They're all sort of, they're not off, but they're scraping the bottom of the barrel or whatever. So I think that's cool too, is when you look at labs from the with the right side of your brain a bit too, and just sort of try and find the red thread, put it all together.
Yeah. Put it all together with the symptoms and everything else that's showing up. Totally.
Which takes a while. I mean,
it's
not like I found some red on your lab. Good, here, call. That's it. You know what I mean? It does take a while. How long does it take you guys to go through lab review with people usually?
Oh, it's a good 15 to 20 minutes because I'm going through everything with my clients. They appreciate it.
Yeah. Yeah. No, I know. I literally had somebody today where we booked a half an hour. I don't know what I was thinking. I booked a half an hour follow-up. And I was expecting to get through.
I know what you were thinking, I bet, Justin, but I'm not going to say
that?
it. I'm not going to say it. I'll tell you after.
Poor time management. That's one of the ongoing joke with my wife, that I fly by the seat of my pants. It's like the story of my life. But anyways, so yeah, I figured like, let's do half an hour. We'll talk about nutrition. We'll talk about the blood work. And like, we barely got through the blood work in that amount of time. And because there's so much to it, like I break down, and you guys probably do too, I break down every single lab that was done, even if it wasn't abnormal, just because people love to hear like your kidney is functioning very well, or your kidneys are functioning very well. And you know, there's no signs of a bacterial infection or a virus or allergies. Like I try to go through it as thorough as possible. And I always go through their previous stuff too, and I'll compare. If I'm able to, I'll compare it to get a pattern. Like, oh, your ferritin was a 7, and then it went up to a 20 after 2 months, and now it's up to an 80 after 6 months, just to kind of, go through that. But yeah, I don't know where I was going with that. So thyroid panel, good thing to do.
Yes.
The rest of the panels, I don't really. Do you guys do the other panels at all? Like,
the only panels I really do, and if I suspect thyroid issues, then obviously that one, which is I think about $100. I'm also looking at those anti-TGs on that thyroid panel.
Oh, the anti-thyroid
globulin. Yeah.
Right,
so
right.
I'm basically, one of the reasons I want to know if there's antibodies is I always say, look, lovely patient of mine, I'm like, you've got autoimmune disease, and every time I have someone with autoimmune disease, I cry a little tear because it's just a little bit harder, and I feel bad for them. And I think in terms of like building expectations for treatment, I want to know if antibodies are there, because I want to be able to tell them, look, you've got some autoimmune stuff going on, and I'm sorry, but you're gonna have to work harder than someone who didn't.
Yeah.
And so I like to know that. The other one I do for panels a lot of the time, which will be of probably no real surprise to you guys, is the liver digestion panel.
Yeah, I do love that one. But I find that if I just do, because I'm getting a lot of people who haven't seen their medical doctors in 2 to 3 years because of the pandemic, or and don't eat. Can you remember the last time they had blood work? But they have so many things. So I'm just like, let's just run a comprehensive. Let's just be thorough right off the bat. And then we can be very discerning after, because there's so many things happening. I'm like, ooh, I bet you there's a lot of pieces that connect. And I'd rather just be there up front. So I find, but I have independently run that liver digestive panel, and I find that interesting to see those liver enzymes
$10.
a little bit elevated. Yeah. It doesn't cost a lot either.
It's $10.
Yeah, you save quite a bit there. And then one thing I wanted to mention about the thyroid antibodies too, if you want to say that there's something cool about them, is that now we have something to measure objectively our progress for their autoimmunity or for their thyroid, right?
Yeah, exactly.
And it's cool to see that, like, you know, they're at maybe a 300 and you replete their vitamin D and it goes down to a 150, and you take wheat out and it goes down to an 80. Like, it's kind of cool to track it that way, right?
Yeah. So you said vitamin D. What's your sweet spot for vitamin D? Where do you typically want to see people when it comes to lab work, Justin?
I prefer 120 to 160. That's kind of my sweet spot.
Good zone.
Yeah, good juicy zone. I've had patients symptomatic in the 80s and like some pretty crazy things. Like, I just had somebody actually where I didn't even expect it, but they had carpal tunnel syndrome. I think they're between like 80 to 85, and I got them on vitamin D, no other interventions, and the carpal tunnel syndrome actually resolved. Just, yeah. And I've had patients in like the 50s with bone pain. I had one in particular who was like really bad bone pain and getting worked up for like bone cancer, and they were doing bone scans and all this crazy testing. No one tested vitamin D, and it ended up being, I believe it was a 56. And while she was on vitamin D liquid for like maybe 3 weeks, and the bone pain was completely gone after that. Like, it's just crazy the amount of things that it can contribute to.
That is one that I tell people, I say, look, if you're okay with it, let's just run it. Like, I find 35% at least of my very sort of predominantly Caucasian pale people are low, and you know, arguably that's one of the only reasons to have this pale thin skin is to make sure that your vitamin D doesn't, like, you know, go into the basement in the winter.
Right.
And I find even in the middle of summer, like I don't have a seasonal sort of preference. I get it in everyone, because like, guys, come on, like, how many issues don't have implications for vitamin D? Like, it's so important, right? And that's $37 well spent. You're going to spend it with your medical doctor anyway, if you even can. I'm like, I got about 3 that I'm no nonsense with. It's vitamin D, the iron panel. That's probably you know what? It's at least those 2 in terms of vitamins.
CBC, right? Probably CBC.
Yeah, sorry,
vitamins.
Like vitamins. Yeah, like I used to run vitamin B12 more, but it can go kind of. You can get some whack.
Yeah,
stuff.
I find it can get really variable depending on where people are in their healing crisis.
Yeah. That's true.
And then Paul Anderson, he wrote some interesting stuff about vitamin B12, how it can, when there's hematological issues, sometimes it's falsely elevated. You get some weird, like if someone's not taking B12 and their B12 is really, really high, that's weird and it needs to be investigated. And then I think I learned about, you know, there's another one where levels are important. Like I think in Japan, the level of low vitamin B12 is like 500 or something.
Starts at like 600 to like 1,000 or something. And I'm like, why is ours
better?
Yeah, because what's ours, like 167 or something like that?
138. I think it's 138 to 652 or something.
Something ridiculous like that. And then they're always flagged at like 700. I'm like, no, you're fine.
Yeah, exactly. And the other thing is, like with that one, I think it even says, I don't know if I've seen it on every time I've got it back low, but on results, it'll say like half of the people or 1/3 of the people with a level below this will have like irreversible nerve damage. Well, that sucks.
Yeah.
I know.
Like that's not optimum.
Why would we want them hovering around that edge?
Yeah. What a low standard.
Yeah.
Well, you know what standards. I see clinically, anybody before 400 seems to have limbs that fall asleep a lot quicker.
Yep.
And everyone can relate to that. So I usually try to get them, if it's, you know, below 400, they can kind of use that as a barometer if they're feeling better, which is kind of cool.
Mhm.
But vitamin D, yeah. Another thing that's important with that too is to make sure that we test calcium levels with vitamin D, just because if the calcium levels are high and you take vitamin D, you can be at risk of kidney stones fairly easily. So I always test those two hand in hand.
Which one are you testing? Are you testing
Just
regular
the serum.
serum? Okay, not your ionized.
No, I just stick to the serum.
Calcium.
Same. Yeah.
Yeah.
Mhm.
And yeah, I always recommend watching out for that. And if somebody is going to go through their family doctor, just to make sure they ask for calcium as well, so we know that, because no one wants kidney stones.
Any other electrolytes? Are you measuring at the same time? Are you measuring any sodium, potassium, magnesium, any of that stuff?
You know what? Like I do them here and there, depending if somebody's doing like, overexerting themselves or they're feeling super lousy in the mornings. But are you like, do you mean just in general or correlated with vitamin D?
No, just like in general, like because I'm torn on that one. That's one that recently I've been ordering more just to get an idea from a kidney perspective and nervous system perspective. It's hard because you kind of have to, they're only a couple bucks each, but you kind of do have to experiment in a way, because clinical understanding of things is not always the same as like what we just get taught or read in books, right? So I'm trying to find correlates a lot of the time, and trying to do like how you've done with iron. You find correlates of, okay, it's actually this level where I clinically find this is very relevant, even though the levels might be normal or whatever. I don't know. I'm trying with like twitching. Say someone's got twitching and sort of
for
like,
sure.
yeah, then I'm going to look at electrolytes, and then
Yeah.
it's interesting to have a view of their kidneys from that perspective too.
I think like you touched on too, is that most references for labs are still speaking about reference ranges. So that optimal area or even ratios, like what's my potassium to sodium
that's
supposed to
another
be?
good
What's
one.
this? And ratios and stuff. And even like when we talked about on the parasite podcast that I had with you, and I was talking about the ratios of the white blood cell breakdown, the differentials compared to the total, and looking at percentages and not just what's in reference range, because there's supposed to be a certain ratio of them.
Yeah.
And I find a lot of things for lab references, they don't give you that information. So you have to start to just be more that, like, for lack of better words, detective, even though we use that a lot. Like there's not a lot of those references that help you really put the pieces of the puzzle together.
Yeah.
Agreed. I also find with the electrolytes that it's very rare for them to be like, even if somebody is like dehydrating the crap out of themselves, they're rarely abnormal on paper unless somebody's like 3 days in a hospital or their kidneys are screwed, right?
Yeah.
And so I do look at them, like if somebody's coming with palpitations, twitching, I'll check them to see if like potassium's too high or if they're having like a lot of coconut water and stuff like that. But I find that I'm interpreting them more coming from the conventional docs rather than me running them personally.
Right.
Just because I don't see them outside of the, like, you know what I mean? They're, I don't know.
They are more like suited in some ways to like more acute care. Like I know if you go to the you go to the hospital with the emergency room, they're going to run your electrolytes most of the time, just because they're, I mean, I talk about this with patients too, like hierarchies of importance of things, like pH, electrolytes, blood sugar, oxygen. It's so boring. This stuff's so boring, but it's so important to remember though, right?
Yeah.
That's why I'm glad you brought up the insulin and fasting insulin and fasting glucose too, and that's a newer thing I've added. And I think that's
me too.
Is it?
I know, I haven't. I was doing.
We didn't learn it in school too much, right?
No, but the fasting insulin, and recently I've been doing
that HOMA IR is what you're looking for when you're doing
HOMA IR. But I've also been doing the insulin glucose challenge recently to see how things move on a 2-hour mark, because that's also even more functionally relevant than just a static number. And I'm trying to understand how to decipher that one too, because that's important to see how the body actually moves. Because some people overcompensate, undercompensate, like it's wild to see those results coming. And I've only started running it a few times, so I'm hoping to get a little bit better at that one.
I'm interested in that test, but I feel like patients will hate me if I send them.
Oh yeah, I pre-warned them. I was like, don't hate
the
me.
2-hour one.
You gotta drink a disgusting drink. But if I think it's really relevant, if I think that it's enough for me to understand insulin versus glucose fasting and do the home IR, I do that. But then there's some of my clients where I'm just kind of like, especially weight loss clients who are really struggling. I'd like to know how that dynamic is happening. So
yeah, no, that test is huge. And I literally, I think I've been running it maybe in the last year and a half. And I'm like, how the heck have I not been known about this or been testing it?
Same, man.
It's crazy.
even just doing home IR, there's so many people who are insulin resistant. And I was like, I'll literally tell them, go ask your doctor. And they're always like, you don't need this test. And then I run it and I'm like, can you go back and show your doctor that you're insulin resistant? Can we have this conversation now?
They still won't believe them though, because they need to see it above that like 180. You know what I mean? Like the objective.
Oh man, it's crazy.
I know
that one drives me crazy because of those hierarchies of like blood. I remember from teaching physiology briefly, that's one of the main causes of aging is glycosylation of tissues. If you don't get a handle on like blood sugar, it ain't pretty.
Everything is masked.
It screws up everything. It's like not having enough oxygen. Dumb, never good, never good.
Not good.
And it's, the conventional understanding is you're fine. 20 years later, you've got diabetes. Like, no, you don't.
Yeah.
You had insulin resistance for the last 2 decades, you numpty.
It's
like
only you're fine until you're not fine. And then it's like, oh, all hands on deck. And it's like, yeah, but you could have just looked at this in the years prior. Same with vitamin D. I just want to circle back. I've literally had people come back to me and say their doctor thinks it's irrelevant to run vitamin D because it's always low around this time. So there's no point running it. And then they don't even recommend anything. And I'm like, how is this? Well,
wait. I think there's if this is Ontario,
give
a little. So you have to give a little bit of extra. I worked with a medical doctor briefly for about 1.5 years, and he was cool. He was starting to test like vitamin D and stuff because he could do it for free at that point. And OHIP gave him a notice. They said, stop testing, just assume everyone is low.
Right.
And I'm like,
but nothing was done about it either.
Yeah.
Exactly. There's no follow.
And then he's like, it's normal to be low at this time.
But they have to follow their,
never normal.
I feel bad for them in some ways, right? Because they got to follow their damn algorithms, and they'll get dinged if they test stuff they're not supposed to in the wrong order or whatever.
And that's what I tell clients, because they're like, why won't he run if it's so important? And I was like, well, they're probably being told they're not allowed, or there's certain restrictions of what they can and can't do, which is why I try to encourage them to just run things through me, and then we can just get the job done. But it's mind blowing. Sometimes people come back and they're like, I don't understand why my doctor said that. And I'm like, well, let's just run it.
Yes.
Move forward.
I feel like a bit of a conspiracy theorist when I say it, but I do think it's a way of increasing global sickness. If people don't know where their vitamin D is
you're opening Pandora's box, Justin.
Didn't expect to hear that from you, Justin.
If you don't test people's vitamin D, and a vitamin D deficiency will increase your duration and decrease your ability to fight off infections and viruses. People are going to be more sick. They're going to be more tired, more depressed, no motivation. It's going to lead to osteoporosis, osteopenia. And this is heavy, but the deficiency can predispose you to certain types of cancers as well.
Yeah.
And so it's like, why not stop testing it and just shove it under the rug? And then
maybe that's why they also don't do fasting insulin, since insulin resistance is a huge driving force of chronic health. And that's why they don't ask people to go fasting cholesterol. And then they get like, your cholesterol's high, here's a statin. Like,
those are easy hits. Those are easy hits, right? Those are easy hits for I think the conventional.
I would like to assume that doctors are doing their due diligence with what they think they're doing. But then on the back of my mind, I'm that conspiracy theorist like you, Justin, being like, is this basically to drive profits in a certain direction?
No.
Like, I don't know.
I don't think it is.
But
I honestly think they're just the system. They're just following.
But that's what I mean. The source, like the root feeding into the system. I don't mean like family doctors individually. I feel like it was I
think the system is built in a way that.
Yeah, it's got flaws. Oh my
God. There's flaws. Let's say flaws.
Oh, yeah, there's
flaws. There's flaws. There's lots of flaws.
Okay, Justin, I want to ask.
Yeah.
I wanted to ask you about another one, like another couple of tests that I run all the time, and just get your perspective.
Yeah.
See, I used to run HSCRP, high sensitivity CRP. Now they don't seem to run it. So I had to sort of recalibrate my understanding of CRP. But
Well,
CRP,
they say to interpret it within the CRP now, right? So if there's CRPs around like a 2 or a 3, they're saying that you're supposed to interpret that as their HSCRP.
okay.
Oh,
Well,
on a side note,
They've run it
too,
for me when I've asked for it.
HSCRP?
Life Labs has. I know Dynacare does, but Life Labs won't.
When I've run
use
it's on
Dynacare.
I'm pretty sure that's one of the ones on the comprehensive healthy living panel, and it's the high sensitivity one, and then it's always
Maybe
run for me.
I got sent a notice
loophole.
that they're not running it anymore.
Really?
Yeah,
me too.
Interesting.
Because
You know
I
what
ran
else I
it
got?
on everyone.
Yeah, I was too. It's such a great.
Maybe that's why they're
marker.
like, you're spending too much.
Yeah. They also, I just got an email saying that the SIBO testing is being
that one's from ICL.
hmm
Yeah, because
But other labs are okay to do it.
yeah, yeah, I don't know. I guess that one because it has to go through the hospital with a breath test, and they said something about there being
Not a
lack
great
of-
time to do a lot of breath tests. You know,
Well,
for
I mean,
emergent cases,
Yeah.
I bet that's what they're thinking.
So
It's a kit though, isn't it? Like, don't they bring the kit home and provide the breath sample and then ship it off to the
yeah,
hospital?
they do.
think
I know
that's
that
how
there
it
was during the last 2 years, it's been on and off with certain SIBO tests because they are quote unquote breath tests, and some of them were completely removed from our ability. And then the one that goes through, is it St. Mary's? I can't remember which hospital it is,
St.
but there's
Mary's.
some hospital, and they just said due to lack of personnel because of the Omicron.
Yeah, understaffed. Yeah.
So I was like, okay, yeah, that literally came out today, didn't it?
Yeah,
Yeah.
it did. Sorry,
Okay,
Dave, I didn't mean to
yeah.
cut
So
you off
back,
there.
that's okay. So back to the ESR and CRP. Just your thoughts on those $2 tests.
Yeah, I like to run them because they are so cheap, but I always will warn the patient that they're not 100%. Because I've had people with like disfiguring rheumatoid arthritis and their CRP and ESR was completely fine. And then I've had others where we're like, we don't know what's inflamed and they're through the roof. But I do, there's kind of some patients where when they're slightly elevated, then you can at least use that as a functional marker of like reducing their inflammation. So I do run them often, especially because they are so cheap for sure.
So what do you consider slightly elevated for the two of those, for ESR first?
ESR, I don't like it to see it above a 12. I know their cutoff is a 30, but it seems to correlate clinically. Like if it's like a 12 or 15, they definitely have some inflammation going on somewhere.
I go
And
even
then if
lower.
it's
I've gone
lower,
lower.
yeah.
I've told between 2 to 5. I've
2
heard
to
some
5,
people
okay.
reference that.
Even like, yeah, when I see 5 or 6, I'm already, because I see so many, I do it on everyone because it's $2. I do it on everyone. And because of that, I think I've seen 5, 6, 7, that level already start to show a bit of like,
okay, that's
stickiness.
good to know. Yeah.
I've
See,
heard
that's where the
I've heard 2
clinical
to 5.
experience comes in.
Yeah, yeah. What
2
about
to 5,
what
yeah.
about HSCRP? I've always heard under 1 is ideal.
HSCRP under 1 for sure. And then the CRP, you could kind of interpret it the same way, right? Like I know their cutoff for that is a 5, but I try to just get it as low as possible. And when you have these like health freaks that come in, usually theirs is undetectable, right? So I do strive to get it as low as possible. For sure. One thing with the ESR too is that if it's like super high, that's when, and if they're having headaches, that's when you want to rule out that temporal arteritis or any type of artery inflammation, right?
It's also a crazy high. It just seems like a crazy high cutoff. Like I had someone, I think they had polymyalgia rheumatica, and I think theirs was like 43 or something. And this person was like debilitating polymyalgia rheumatica. Like if that is just breaking into the zone of, I mean, like, yeah, I don't know. I found that to be kind of striking.
I know. And you'll see like somebody will be up there and then they'll go down to like a 20 or an 18. And because that number's fine, they're basically like told that they're okay, even though they're still, suffering. Right?
Yeah.
Crazy.
What's a couple other ones you find yourself checking a lot, Justin?
Liver enzymes for sure, ALT, AST, and I do like to see those in the teens. I find clinically, if they're like in the 30s or 40s, it's usually contributing to fatty liver if it's not due to like alcohol consumption So yeah, I strive to get those into the teens. I am starting to starting to test albumin a little bit more, because I have noticed that if albumin's elevated, that actually seems to show up in blood work in dehydration more than the electrolytes being
Oh yeah.
imbalanced. Yeah, and as a bonus, you're testing their liver and like for any crazy liver kidney pathology. So it's kind of a good test to do.
Mm-hmm.
I offer the blood typing as well, because some people are interested in that. I know there's a lot of controversy over that, but I'm more instead of it guiding what you're eating, I always recommend people putting it into their phone, into that in case of emergency thing, and then if they get into an accident, paramedic can see what their blood type is, which is kind of cool.
Never actually thought about that. What's the cost on a blood type?
I think it's like
It's
$10.
inexpensive. Yeah,
Like
it's
$10
inexpensive.
probably, right? Like it's like
Yeah,
can't be
yeah.
much. Yeah. Okay, cool.
Yeah.
Never thought about that.
I rarely run aldosterone or ACTH. Might as well just go through. And I do run ALP quite a bit, alkaline phosphatase. And I'll run that, especially if somebody's having upper abdominal pains, because it can be an indicator that the common bile duct is inflamed if it is high.
That's a good one for clinicians to know. Good one.
Yeah. I rarely run the amino acid fractionation, quantitation, or whatever that's all about. I do run if somebody comes in with abdominal pain, or you guys will like this, if their stools are kind of weird, I'll run amylase and lipase as well. And obviously, if those are high, they indicate amylase will indicate chronic pancreatitis, whereas lipase will indicate acute pancreatitis. And if they're low, then if amylase is low, you're not going to be digesting carbs very well. And if lipase is low, you won't be digesting fats very well. So those are kind of cool. And those are super cheap as well, right? They're like $8 together, I think.
I didn't know that. I didn't know they're that inexpensive. That's good.
I've honestly never run those enzymes, even being in gastrointestinal health. I've never run those enzymes, because usually just like by looking at their poops and looking at other things, I'm kind of like, all right, we got to support some stuff there. But
well, I got into them because of my own bout of pancreatitis, actually.
Oh, yes.
It was the beginning of the pandemic. Like all of a sudden I went to a stag and doe. I woke up the next day and I was like suffering big time. And a week went by and I'm like, I'm not getting any better. Like, this isn't food poisoning. So I went, and I couldn't get into my doctor. So I went to a Life Labs at the time it was so fresh pandemic. The only screening question was have I been to Wuhan, China in the last week or two? And so I had the blood work done, and my lipase was through the roof. And then I had, that kind of got me in, just like experiencing hemochromatosis got me into the iron. I kind of did a deep dive into the pancreas, and I've caught on to quite a few cases of pancreatitis that, because personally, when I was getting these little hints of pancreatitis and I thought it was indigestion, like over the years, and then all of a sudden I got it like super intense, and then I realized it was my pancreas that was inflaming.
So it was chronic because your lipase was elevated, right? Okay.
Well, it was acute because the lipase was elevated. The amylase is for the chronic. My amylase was fine, but you kind of have to go, like, if somebody is actively experiencing that pain at that time, you want to do lipase. And if somebody's just like here and there, maybe like weekly getting abdominal pains, that's when amylase would be more relevant. But I just test them both together because they're so cheap, right?
Yeah. Nice.
But yeah, they can be very useful. And then that sometimes will indicate, like, let's say if amylase or lipase are low, it'll indicate that maybe they have to go on a digestive enzyme for a bit, or do something to help their pancreas secrete those enzymes a little bit better. We do have access to anti-Mullerian hormone, which I don't really test too often unless it is a fertility case. It's nice to see that number. ANA, I do test a lot as well. And this has been another infuriating test that I run. I'll test it if there's like random pains, like they can't determine the cause of whatever pain is going on, or if they have Raynaud's, like there's quite a few indications. And it comes back positive. And I don't know if you guys have the same experience in your area, but when I send this test to a rheumatologist or an immunologist, it is not a fun experience. They do not like when I run this test and it becomes positive, and it's nothing but backlash after that. And it's very unfortunate though, because then that, like, they're not able to get the ENAs run, right? Like the extractable nuclear antigens, which is the next step to figure out what's going on. What about you guys? Like, have you guys had that experience at all where you find a positive ANA and catch some flack? Or
Most of my ANA clients were already investigated because of chronic
Same.
issues.
Yeah,
So
same.
they were done through the medical system and come back, and then but still being like, we don't know what to do with this. Here's some steroids. And I'm kind of like, oh, okay, let's heal your gut.
Right. Yeah. No, I am like very frequently the first person to find a positive ANA. And I do run it a lot in chronic hives and see a positive come back as well. So yeah, that's a key test that I do like to run.
Chronic hives, eh?
Yeah, especially there's been, I don't know if you guys have seen a lot of that, but it's I am seeing a lot of these cases since, like, I would say probably last November, there's been all these cases where all of a sudden they just have hives and they're just trying to figure out what's going on. Some of them are autoimmune.
I had a guy just recently, rashes, like crazy rashes, but only since the vaccine. He got vaccinated.
Okay.
Yeah.
Through his immune system for
I think so. I mean, I'm no, like, I could get crucified for saying all that sort of stuff.
But also, even with like long COVID, people's long-term reactions. And I was just doing something about that through Health Masters and talking about how the immune system and people's resolutions and inflammatory markers and the gut microbiome having a lot to do with that. And a lot of weird random stuff come up as like just long COVID, I think too. Right? People are just not rebounding the way they need to because we were all already unhealthy as a society to begin with. So it's really difficult to recover. Right. So, I mean, that's it. Yeah.
Okay. I have one other one before I see that time is running out. I have another important one to go through. And then, yeah, we should do a part 2. We could probably do a part 20 if we really wanted to.
I know.
And I do love this. Like I told you guys are great to talk to, and I love discussing blood work because I feel like I don't get to talk to anybody else about it. And I tell my wife, she's like, okay.
I know. I tell James and he's like, can you stop being a naturopath already? Can we just like watch a Marvels movie and just okay.
So let's nerd out for a few more minutes. Like give us a few more like top hits for you.
Yeah.
Okay. Creatinine, EGFR is huge, right? And creatinine is more of an indication of how much protein your body's dealing with leading into that test. And EGFR, or estimated glomerular filtration rate, is your kidney function or your filtration rate of your kidneys. And that GFR is directly correlated with the creatinine. So the higher the creatinine, the lower the GFR. Optimally, I like to see the GFR above an 80. And if it's below a 60, that's when you definitely have to worry about the kidneys. And I've had a couple cases, because this is another test where they're not told to fast. And I had one case in particular that stands out, but a lot of them. But this one guy, he was doing paleo. He had a roast in the morning. And so I should take a step back. So he approached me saying that he had stage 3 kidney disease because his GFR was down to like a 40. And I said, I said, well, did you eat anything the day of the blood work? And he's like, I did the blood work around noon and I had a pot roast for breakfast. And this was my first visit. This, like, I wasn't the one who said eat pot roast for breakfast or anything. So I tested him fasted, and his GFR went from in the 30s or 40s to the 80s or 90s.
Damn.
Way.
Yeah. And the closer you have a high dose of protein to that blood test, the higher your creatinine is going to be. And then all of a sudden that's going to show that low kidney function. So I always recommend doing it fasted. And even then, if somebody has a crazy high protein dinner, I'll say, like, take it easy with the protein on the dinner the night before if you're going to be testing at like 8 a.m. And it usually does show a lot better.
See, Justin, that's why you're going to keep getting calls to come back on the show.
Well, thank you.
Isn't there
But
something about also thyroid testing being fasting? I remember hearing something about more recently that we should be going in a fasting state for thyroid. Have you guys heard that?
The only thing that I've like it says
you have the
fasted
option, right?
around.
Yeah,
Yeah,
you have the
yeah.
option.
I usually just say go fasted no matter what. The only
Right.
exception to that would be if food aggravates somebody's digestive system. Sometimes I'll get them to actually aggravate their system and then go test their amylase and lipase and
Mm.
GGT and ALP. But otherwise, I just recommend getting it fasted no matter what. The only thing that I've heard of with the thyroid panel is that they should not be having biotin, anything with biotin in it for like, I don't know how long. I usually just say make sure it's been about a week or more
Mm.
because biotin can throw so many different tests off. That's actually an important concept for this
I like
test
that.
or for this talk too. Yeah, they use biotin in the assays for something like 30 plus tests. And so you can get falsely abnormal results if you took like 10,000 micrograms of biotin.
Cool. Never
leading
knew
up
that.
to it. No,
So that's
yeah.
good clinical
See?
pearl, Justin.
That's why
Thank
he's
you
on the
very
show.
much. So yeah, creatinine, GFR, I run all the time. And like I said, if you guys ever see that, just make sure, because they're telling people that they don't have to fast anymore. And I have a suspicion it's because it's so hard to get into labs these days. They're just saying like, go at 3, don't worry about fasting. But then all of a sudden these type of issues are popping up, and then somebody's falsely being told that they have kidney disease or that their cholesterol's high or whatever, right?
Yeah. And not everyone can be there all at 8:00 to get their fasting labs done. So I
Yeah.
imagine that's a bit of a shit show for the labs.
I know, and they're apparently understaffed these days as well.
Who isn't understaffed these days?
I know. Somebody just wrote, it was an Instagram post, and he took a bunch of pictures of like help wanted. And they're like, what is going on these days? And I was saying, I think it's because I'm telling too many of my patients to pursue their passion and get out of their toxic workplace.
Right. Oh, geez.
Which can be the best thing for your health.
Really? It's
yeah.
unbelievable.
100%.
It's like just as bad as being in a toxic relationship. Like it's when patients come in with like migraines and they know their job is toxic and the people there are toxic, you can give them all the magnesium and whatever you want, but it's not going to go away till they leave that job for sure.
Yeah, no, I know that's a hard pill to swallow, but it's true.
It is.
Yeah, I do want to talk about the CBC, but I think it is expansive enough that we should just start maybe part 2 with that.
Sure.
Because the CBC, there's just so many factors with it. So
yeah.
And maybe to leave this off, celiac testing is covered by OHIP from now until January 24th, apparently, if a family doctor does it. So
Cool.
get those patients in to do their celiac testing if it's
No,
indicated.
It's great.
And only 1/3 of adults with celiac disease have digestive issues, which
That's
is kind
it.
of crazy to think about.
I've had to tell people that. There was always this one wild story. Was it Jonathan Beatty told me? Because he deals with like a lot. Yeah. And he said he had a client who was diagnosed with fibromyalgia like 15, 20 years prior, chronic aches and pains, comes to see him, does food sensitivity testing. They do a celiac test. It comes back positive. She goes for the biopsy and the technician was like, yo, man, the destruction in the intestinal tract was unbelievable. Probably like 15, 20 years. Coincidentally, when she was given that diagnosis, they cleaned things up. Not a digestive issue at all.
Mm-hmm.
Weird.
And then fibromyalgia, in quotations, went
I
away
know.
after getting rid of so like it's not always going to show up with gut issues. So I hear you on that one.
Yeah, let's leave it with that. That's a good nugget.
Yeah,
It was a good nugget. We'll talk. Well, you know what? We'll have to talk about fibromyalgia another time too.
Yeah,
That's a interesting topic.
it's a diagnosis of exclusion, but nothing's really ever excluded.
Yeah,
And then it's
up there.
diagnosed.
It's up there with IBS, eh, Michelle?
yeah. I was just gonna say.
I know. There's
Yeah.
I tell people, well, you guys probably might say this too, but I try to rename IBS IDK because they're just saying I don't know.
Yeah.
Yeah.
The fancy term. It's just like if somebody has migraines, just saying like, oh yeah, you have chronic migraine syndrome. There's your name for it. So live your life now, right?
There you go.
Here's a painkiller.
Yeah, that's right.
Yeah.
All right.
Okay.
Well, thanks for having me on, guys. This was awesome. I appreciate it.
Yeah, thank you for coming on. We'll do it again. And it's all the other stuff, without trying to blow too much smoke up your arse. It's
You can blow it all up if
okay.
you want.
It's the important details that a guy like you is going through that I really think people will enjoy, clinicians and people like the idea of eating that protein dinner before the creatinine. Like, man, that practical side that you bring to this sort of stuff is the profession needs it, and patients need to hear it too. So thank you so much for bringing that.
Thank you. Thanks for having me on. And yeah, we'll do the next one soon. Send me that invite.
Okay, we'll do it.
Love it.
Okay. You guys have a good night and a happy new year.
You too. Happy New Year.